Thank you for the previous lectures, which was really scientific, and we're going to outcome, which is really perhaps less scientific because it's Claire says that it's clearly a tailored approach for these patients. They come, some of them have very clear symptoms, that means they bleed and nothing else, and some of them have plenty of symptoms, and it's very difficult to give a good indications and also to give a good outcome. So the patient's follow-up and evaluations is really, really difficult. And the first question is, what is the definition of the clinical success for that? For cancer, it's really easy. The patient is alive or dead. That's a clearly binary. Here, you have pain in the ass. After you have mild pain or more pain, less blood, more blood. Very difficult. Some patients come and said, I'm not very well. I said, oh, okay, you're still bleeding. No, but I have pain here. I said, okay, but it's not me. But they are not still well. So, I show you this Lancet paper, 2016, Haemorrhoidal artery ligation versus rubber band ligation. So we're not speaking about Emborroids, but we're speaking about how to evaluate. It's a randomized control standard in Lancet. So clearly, so how they have evaluated the clinical success. At 12 months, in the absence of validated symptom scoring system, absence of scoring system, okay, the success was patients' reported outcome of improvement, and of course the need to avoid any additional procedures. So that means that for this study randomized, they take the phone and ask at 12 months, at the moment, do you feel symptoms from hemorrhoids are cure or improved, or unchanged or worse? And I think they are completely right, because the patients don't take care of, he just wants to be free of his symptoms. And finally, the secondary endpoint was some score. So look at this score. So in this score, you have some questions about pain, itching. So you have this, how often do you have pain from the hemorrhoid, and how often do you have itching or discomfort? What is the difference between discomfort and pain? It's better. And here, how often you have bleeding when passing a motion, or how often you have soil under clothes. Sorry. So let's take this score. So this is a patient which is 35 years old. It's like a very active man. Is stage 2. He has no pain, no discomfort, but he has anemia because he has so huge bleeding. If you go with this score, it's 5. You take the second patient, she's 65 years old, he has a stage 3, he has discomfort, prolapse, and some bleedings 2 times a year, it's 5. So clearly, is these 2 patients the same? I'm not quite sure they're the same. We treat with Claire, with Farouk, and with some patients, we come and which have transfusion, blood transfusions from bleeding. You know? So that's why Saint-Proval and us do the score. There was no bleeding score for hemorrhoid, which is the main symptoms. So it has been treated and evaluated by surgery, but there was no bleeding score. So the first bleeding score don't take care really of anemia. Now we put a higher place on anemia because, of course, these patients. There's plenty of other score, incontinence, pain, surgical complications. Anyway, it's important. Now look at that. We're still on Lancet. Clinical experience indicates that the physical appearance of the anal cushions post-treatment correlate poorly with patient symptoms. Our surgeons say that. They do a rectoscopy 6 months after the treatment. Sometimes they see anything, so just small cushions, and the patient's complaining of some bad results. And if there is a very small part of the cushion which bleeds, for the patients, he sees the bleeding. You don't see that there is 90% of the cushions which are not there. And sometimes the surgeon said, it seems to be worse. The cushions are very big and red, but finally the patients are no more bleeding. So the patients may be happy. So that's really complicated. And there is, in this study, there was no difference between the 2 interventions at any point in the score. And they say that many patients are not concerned with a certain level of persistent symptom related to hemorrhoids. That means that what Claire said, some patients come from, the point was, I have some trouble because I have a lot of bleeding, And also I have a small prolapse, but my problem was bleeding that I cannot wear anymore white trousers. So this is my issue. So after the patients come, he said, how do you feel? I have no more bleeding. I wear white trousers and I still have a small prolapse, but I'm okay. That's clear. And it can be another point. So this is really a functional symptoms. So finally, does it work? And on which symptom? On bleeding, on pain, on prolapse, what is clearly the level of evidence today. So this is the beginning. We began in 2014, and I go to 220 after we have like meta-analysis. What can we say? Of course, there are only a retrospective study. At the beginning, it was small series. The only prospective series has been done with Farouk and us, 25 patients. The follow-up can be very low. I think 1 month follow-up, 3 months follow-up does not mean nothing because we think that there is patients with recurrence. So it was around 250 patients with, what can we say? A technical result, there is no issue with technical results. You have seen what we do. You can go directly with direction, usually without wire. It's not a lot of tortuosity, so it's okay. You see the clinical success. How can you trust this clinical success? Because the clinical success has never been real defined. If you go in some different study, the clinical success will be completely, some with the French score, some with symptoms. Anyway, the clinical success seems to be at least 70%. We are very happy to have given all the time the worst clinical success. So that means that we have not sold the technique. And the agent was coil almost and coil plus fur. So we don't know still what is the best. There is no evidence. There is something. In this series, we had no major complications, but of course, I said it was really poor comparable, except the prospective that we have done, where we have a bleeding score which was clearly decreased. And this was sustained at 2 years, because the clinical success was still 70, and the bleeding score continued to decrease at 2 years. Okay, so now, I don't go back on this paper, which has been said that there was 54% of minor complications rate. That means the pain and things like that. So clearly, microsphere lead to pain. When you put microsphere and when you put coils, there is any pain. The patient said, I feel nothing. So if you put some sphere, you will have. Is it time for liquids? I don't think so. You know I am in love with liquids. I have done a lot of my work on that. But I think it's a bit dangerous. Hafshin Ganji, which is there, which is a best friend of me, and I asked him a lot of things. And do you remember 6 years ago at the French journey, I said, should we be more aggressive with embolizations to reach a higher clinical success rate? The guy says to me, this is functional symptoms. Please do not have complications. It's better to have a lower clinical success with 0 complications than to have 3% complications with a higher success. Thank you. No, because I think it's clear. So at the point where we are, I think we need to be as with the lowest complications rate. Is it time for transradial approach? Of course. I don't do it because I am too old, but Farouk do it, and it works very well. The patients, it's a completely game changer. You have a surgery which anyway will pass from the ass, so you will have a general anesthesia pain. And here's the patient's come, he has transradial access, he can play with his iPhone, and 3 hours later, he's back to work without pain. So it's clearly a game changer. So what about the meta-analysis? So 2 meta-analyses has been done. One will be published in Severity next month. Globally, we go back with the same result. It's around 100% technical success and 80% clinical success. It seems that inserting particles leads to less recurrence because coil is 21% of bleeding recurrence, and when you mix coils and particles, it's 10% bleeding recurrence. So clearly there is some things to do with particles, but particles needs to be big, needs to be inserted in a small volume, and needs to be inserted in the sides, not in the inferior rectal artery, as said already. Look at this paper, Haemorroid with Emborroid, risk of the Emborroid technique. Paper published last year. So a patient has a sigmoidal stenosis, which has been treated by dilatations. This paper needs to be published because all the complications need to be published, but you are an interventional radiologist. In this paper, we don't know where was the tip of the catheter. We don't know either the size of the sphere. We don't know if it's 200 or 900, and it's seen on the images that it has been embolized from the upper side, and someone says me, I don't know if it's right, but the sphere was 200. So of course, if you inject small sphere in the inferior mesorectal artery, you will have a stenosis. It's normal, and it's what you want to do. If you inject small sphere in the inferior rectal artery, you want to have ischemia. So again, try to have better result success. It's great, but we need to be very cautious. So does it work? Yes. There is a result which has been published in Sobrais in Brazil, a randomized study, surgery versus embolizations, which is positive, but it's not still published, so we don't have the final results. So on which symptoms? Clearly on bleeding it works. On pain, it can work, but I just want to remind you that hemorrhoids don't lead to pain. There's swelling, things like that. When you have a big pain, it's usually external hemorrhoids because you have a thrombosis. Internal hemorrhoids, no, the surgeons say that, do not lead to big pain. So when the patients come and say, it's awful, it wakes up me at night, okay, just that it's not hemorrhoids, don't treat him. He looks at anal fissures, it's really painful. Hypertrophy of the sphincter is really painful. So if the patient comes to you directly and he says you that, of course, don't treat him. Go back to colorectal surgeons and have a complete evaluation. On prolapse, we don't know, but as we said, there is so many mechanical issue on the wall of the rectum. If there is no wall and no possibility of just lead the wall of the rectum, you will not fix that with embolizations. One friend of us in Marseille do a lot of mixed work with the surgeons. He do an embolizations first. If the patient is happy with bleeding, but the prolapse is still an issue, he would, after the surgeon, do a small mucopexy. So that means it's a small intervention, and the surgeon is really happy because he said, I don't have to take care after for 1 month of call with the patient. What's happened today, this morning, I have pain. Because she said that, Claire. It's a big issue for the surgeons because for 1 month, they have patients calling. So probably also there is a very interesting way of doing both procedures with surgeons. The level of evidence is still poor because there is no randomized trial, so we need a bigger randomized trial. I have fight to have a randomized trial led by the industry, but like the industry, everyone has calls, so they don't want to do that. We have asked funds from the French government, but the French government don't take care of pain in the ass, it seems. For the moment, everybody has pain in the ass. Conclusions. You need to remember that the hemorrhoid recurrence at 1 year with Doppler ligation is 30%. With rubber ligation is 50%. We are 20%. So that means that we have a technique, a non-invasive technique, which is anyway better for recurrence, better for pain, and better for complications. So clearly have a good selection, straight patients which have only bleeding, treat the middle rectal artery, and for the patient's follow-up, just feel comfortable to ask the patient, are you happy or not? And that's enough. Thank you. Of course, a randomized trial is needed.
Thanks, Vidal. Any question? Okay. I think that we are on time and we have to close this session. Thank you very much to everyone.
Thank you.